Good morning. Welcome to everyone to my presentation. I am Dr. Afroza Akter from Nuclear Medicine, Dhaka Medical College Hospital. Myocardial perfusion and viability assessment prior to revascularization following myocardial infarction and evaluation of functional improvement. The combined evaluation of regional myocardial perfusion and FDG metabolism images allows identification of specific flow metabolism pattern that are useful to differentiate viable from non-viable myocardium as well as hibernating or stunned myocardium. Combined non-invasive imaging protocol using rest-only gated MPI and FDG cardiac PET also can predict the future outcome in non-coronary artery disease patient following acute event. So early assessment of myocardial perfusion and metabolism before revascularization following MI is very much important for patient management. This is my representative case, a 56 years old male patient having history of anterior myocardial infarction and left ventricular failure 1 month back, having risk factor of hypertension, DM and dyslipidemia. On echocardiogram, there is dilated LA and LV cavity, moderate LV systolic dysfunction, ejection fraction about 32% with regional wall motion abnormality. Baseline serum troponin I level was 1.96 with raised NT-proBNP level, which subsequently normalized within 2 weeks. And this is the ECG showing ST elevation and pathological Q wave in lead V1 to V4, indicating acute anterior MI. This is the coronary angiogram of my patient showing severe left main with triple vessel disease. Left main coronary artery disease was highly calcified and other LAD, LCX and OM have 95% stenosis, RCA showing about totally occluded in its mid segment. Now, this is the day 1 and day 2 protocol for cardiac MPI and cardiac PET imaging. Patient preparation needs overnight fasting. After injecting perfusion tracer, we have to wait for 45 to 60 minutes and image acquisition time takes about 20 minutes. And the second one for cardiac gated PET, patient preparation also overnight fasting. After injecting metabolic tracer, we have to wait for 60 to 90 minutes and imaging time about 15 minutes. And the right corner side image showing the 17 segment model through which we perform cardiac storing for perfusion on metabolic defect. This is the myocardial perfusion imaging of heart showing in 3 axis view like short axis, horizontal long axis and vertical long axis view. The blackish area on the polar map showing the perfusion defect. Here we can see there is a large size moderate to severe perfusion defect in the apex and anteroseptal valve mainly involving apical and mid segment with basal extension towards the LAD territory. There is a small size moderate to severe perfusion defect in the apical lateral valve along the LCX territory and mild perfusion defect at the basal infraseptal valve along the RCA territory. And now this is the 3D volumetric data showing dilated LV cavity, moderate LV systolic dysfunction about 32%, and regional wall motion abnormality showing almost akinetic apex and hypokinetic anteroseptal valve. And this is the similar FDG cardiac PET imaging showing mild metabolic defect at the apex and basal anteroseptal valve along the LAD territory, mild perfusion defect in the basal infraseptal valve along the RCA territory, and normal metabolic activity at the lateral valve. This is the similar 3D volumetric data of my patient showing moderate LV systolic dysfunction about 35%, markedly dilated LV cavity as well as hypokinetic apex and anteroseptal valve. Now before interpreting my case, I have to show the simplified classification system of pattern of perfusion and metabolism defect. Here the right corner side image showing the perfusion and metabolism pattern. Perfusion is reduced, metabolism is normal indicating mismatch defect or hibernating myocardium. The second one, absent perfusion, absent metabolism indicating match defect or transmural scar. And this one showing perfusion, reduced metabolism indicating non-transmural match defect or non-transmural scar. And the last one, interesting one, there is normal perfusion but absent or reduced metabolism indicating reverse mismatch pattern or stunned myocardium. That means dysfunctional myocardium with altered glucose metabolism. Now this is the comparison diagram of perfusion and metabolism imaging. Here in perfusion imaging we show there is 24% perfusion defect but about 8%, only 8% metabolic defect. That means perfusion metabolism mismatch defect indicating viable hibernating myocardium. And this is the point, and this is means there is chance of improvement after revascularization. Pre-surgery echocardiogram of this patient showed moderate LV systolic dysfunction, about 30 to 35%, hypokinetic RCA and distal part of LAD, and mild concentric hypertrophy. Then patient underwent CABG with 3 grafts, Lima to LAD, and venous graft to WEM and distal RCA. Subsequent follow-up of this patient showing clinical improvement of symptom. In subsequent follow-up, improvement of left ventricular ejection fraction about 50%, no cardiac event-related hospital admission, even no heart failure. So assessment of bicardial myocardium following myocardial infarction by perfusion and FDD imaging can show significant clinical benefit with improvement of ejection fraction in post-surgical intervention in our presenting case. MPI and FDG PET viability assessment has a significant impact on patient management and clinical decision making, and it can identify those patients who might be benefited most from revascularization. It can choose the most appropriate revascularization approach. It also avoids unnecessary procedure and risk in those patients with minimal or absent viability, and finally helps to minimize cardiac event-related mortality and morbidity. Thank you very much. Thank you very much for patient sharing.